My name is Dr. Kenneth Lee from Vancouver, BC, and I'd like to present this case, a case that I was involved with. The patient is a 34-year-old female who came to me because of her discolored upper front teeth and also involved with endodontic complication that needs to be addressed. As you can see from the radiograph, patient has had endo and also some retrofills, and that's with some failures. At the apex you can see some radiolucency, especially the lateral. The root is really compromised, so I've decided to replace it with an implant for a more predictable long-term solution. Here you can see that the upper left lateral has been removed, and here you can see it has been replaced with an implant. The case was done roughly about around 1995, so at that time the implants of choice that I was utilizing in the practice was the Brennemark implant, the external hex. The case was on surface for a number of years before the other non-vital teeth, the upper right central and left central, had endodontic complication again, in spite of the retrofill that has been done. And you can see on the slide on the far right, the lesion has enlarged. So at the time we decided to address the two questionable central incisors. So I replaced the PFM on the implant with a provisional crown and utilized it as an anchor for orthodontic eruption. The reason for this approach is because of the several retrofill that has been performed. The labial plate of the both central incisor has been really compromised, and there was none whatsoever. And as you can see from the lingual or the palatal shot, the two centrals are completely hollowed out. There's basically no tooth structure remaining for regular full crowns. So the tooth was gradually erupted through selective or forced orthodontic eruption, as much as we could do that, and this is done over a period of about roughly 2 months. It's not too difficult to erupt a compromised tooth with a short root, and as you can see from the radiograph, by erupting it slowly, one could get nice bone formation at the apex. And subsequently we removed the tooth or the reflected tissue, and as you can see, the whole labial plates of both teeth have been destroyed. And the reason for the eruption is it gave me some bone to stabilize the implant when I place the implant. As you can see, there's hardly any bone, and in order to get some form of stabilization, the implant was a little bit placed more apical, probably about 2 millimeters more than what I had wanted to. We subsequently applied autogenous bone, obtained with a bone harvester from the external oblique area, and then we covered it with resorbable membrane. In this case we use a BioGuide, and also with pedicle connective tissue from the palate for the edentulous area, that is the upper left central area. As you can see, we managed to cover the tissue and allow it to heal, and subsequently, after about a week or so, we replaced the two coronal portion of the teeth that we are replacing, that we managed to salvage by cutting it from the roots before we removed the roots, and we used it as a provisional spring. And the picture on the right earlier you can see was roughly 4 months after the implant placement, and after we achieved nice osseointegration for the implant replacing the right central, we subsequently uncover it and then make a provisional crown on it, and then subsequently make a provisional bridge. for an ovate pontic. What we did, rather than preparing the ovate site with a burr, we use a scalpel and then move it to the midline between the two centrals and try to regenerate the papilla. Here you can see the tissue that was pushed towards the midline, and here you can see the case roughly about 3 months later. The papilla has been regenerated quite nicely. I must say that we are very fortunate that we achieved this, because this is not always predictable. And here you can see the original picture on the left side and the tissue that we managed to form with the professional splint. This is approximately about 4 months to 5 months after the implant placement. And these are the interdental tissue that we could sort of reproduce with the professional splint. Subsequently, we took impression and started to complete the prosthodontic work. We made a metal framework for screw-retained 3-unit splint, and the reason for screw-retained is to make it retrievable just in case we have to surface the case or make adjustment or modify the prosthesis down the road. So it makes it easier to manage a restorative maintenance problem. What we did here is we sectioned the frame, but leaving a fine isthmus in there so it's flexible. And as you can see from this radiograph, we secure the 3-unit splint onto the left implant with 1 screw, and then see whether the adoption on the right implant is very accurate. And if it is, then we can proceed and secure the abutment screw to stabilize it, and then elute it with a GC pattern like an index, and then solder the case, and subsequently complete the ceramic work for the 3-unit splint. Here you can see the ceramic work was done the best we could possibly do for the patient, and we inserted, and you can see this is reasonably acceptable. But to my surprise, the patient wasn't too happy, especially when she remembered that her teeth are rather triangular shape, but we suggested that she maintain it for about a month or so and then see whether she liked it or not. Being a screw-retained 3-unit bridge, we can always modify it. So the patient was sent home with this 3-unit bridge, and then to let us know whether she get used to it or not. But you can see there's no triangular spaces between the teeth, so it's actually quite acceptable. However, to my surprise, within about a month's time, the patient came back and indicated that the porcelain on her left lateral has fractured and wanted to know what can be done. So of course, being a retrievable bridge, that's very easy, it's not an issue. So all I did is call up the ceramist and ask him to help us resolve the problem, and he said that there would be no problem because it's easy to replace the porcelain. So he subsequently redid the bridge, and using some of the patient's pictures that we took before we started the case as a guide to remake the 3-unit bridge. And to our delight, when we place a bridge in, as you can see on the left, it's almost mimicked the patient's natural teeth on the right, and the patient was very, very pleased with that, in spite of the triangular spaces that she has between the teeth, but that is her. From this we learned that our concept of cosmetic may not always meet the patient's concept of cosmetic. And for that reason, we have to comply with the patient's need, because after all, they're the one that we have to please. And here you can see the patient is very happy with the case, and In spite of the fact that the position of the implants has not been altered, here you can also see that the ability of the ceramics to create teeth that looks like these and the proper shade is the determining factor to please the patient. You can see here the difference between the two 3-unit bridges that we made for the patient, and I must say that the patient is correct in saying that she likes her natural look, because after all I can see that the new bridge is way more natural looking than the one that we had made in the first time for her. Here's the radiograph, and the case is now roughly about 13 years in the mouth while we talk at this moment, and the patient has been very pleased with it. I hope this case can be of some information.